Thanks, Miguel. So I guess I should first of all say that I've only been in the States for the last 6 months. And prior to that, I spent 10 years in Switzerland working for the International Council of Nurses. And so therefore, I'm going to bring to this a slightly wider discussion. And I'm going to focus at two levels, one at a policy level and one at a very practical level. Because prior to going to the ICN, I was the director of nursing of a very large university teaching system, which included everything from a emergency service drop-in clinics right through to tertiary level hospital services. So let me start off with this example. And the history of this example, which is entitled Positive Practice Environments, as you can see, relates to some work that the International Council of Nurses did with its sister organizations, the World Medical Association, the Pharmacy Federation, and the Dental Association. The physical therapists at this point in time were not part of that group, but they subsequently joined. And at a political level, we recognized that to make an influence on global policy, we actually needed to have a shared message, because what would happen is that one of us would go along to a minister or to the World Health Organization, we'd say one thing, our colleagues would say the exact opposite, and as a result, we wouldn't move forward on anything. So we came together and we identified that one of the issues for all our professions was about what we call a positive practice environment, which is an environment within which education and clinical practice can excel. And therefore, part of the discussion we had was, well, if that's the case, then how do we bring the stakeholders together as part of that process? We recognized that there were multiple actors involved in this. So yes, there were medical accreditors, there were nursing accreditors, there was hospital-based accreditors, etc. And we tried to figure out how we would collaborate together, and as the previous questioner raised, how do we respect what each other does? And by bringing people together to simply say, well, you know, what's working for you and where are some of the problems, and can we agree to capitalize on those positive experiences, and can we work on some of the shared problems together? We came up with this idea of moving forward with the positive practice environments. So during this period of time, there was something called the Global Health Workforce Alliance. It made some funding available, and we identified a number of countries where there were accreditation desires, but no systems in place. And the deal was that at that time there was the four groups involved, that any country that could get the support of 3 of the 4 groups we'd be interested in working with. So we were really looking from moving from either no system or a series of parallel systems to a much more of an orchestra approach, where we could try and understand where the data was coming from, try and capture it once and use it many times as part of that process. So we really needed to step back for a moment, and then the comment I made this morning to our keynote speaker about realizing that there were many more accreditation systems, of course, is one of the things that you identify as part of that. They're really quite pervasive in terms of all the demands. And again, before lunch, there was a rather animated description of the volume of work that sometimes has to be submitted. And what we tried to think about is, well, how much of that is common? How can we actually reduce some of that work so that there's a common pool that we can rely upon as part of that process? So we made some funding available. One of the requirements was that all the stakeholders had to be around the table, and there had to be some community involvement from the patient perspective as well as part of this. And this resulted in 3 pieces of work being done in different countries, and each of them were able to agree a way forward and go jointly to the ministries of education and health, because one of the problems is often you have the hospital accreditors reporting through one pathway and you've got the education accreditors reporting through another pathway, and lo and behold, the ministers never talk to each other. So part of this was actually to move this agenda forward. So by doing this, we were able to engage in a dialogue where there was a joint commitment to move forward on a number of issues. And the issues like, how do we make sure that we do have a learning environment where supervision is available, but it's not going to be pressurized? Because what we're looking at is a mentorship, questioning type supportive dialogue rather than necessarily a technical piece as well. And there's room for both, but it's actually about how can we capitalize on that? Because in some of the countries that we were working in, there was only maybe 2 or 3 people in one of these health stations, very remote, and therefore how do you capitalize on that? So this is one example of how, by bringing not only the education accreditors and the health system accreditors together, but the disciplines together, we can be much more politically effective in terms of effecting change. Let me just move to the second example. And this is a much more pragmatic piece of work. So I was appointed as Director of Nursing to a university teaching system. It was a failing system at the time. People were not communicating with each other. And part of the problem was there was a disconnect between our education provider and the service provider. We were complaining about the fact from the health service side that the educators didn't really understand what we were doing, that they were producing people that we couldn't use, et cetera, et cetera. So that whole education service gap was writ large in terms of the position. Well, I asked the question, so how do we communicate? How do we work together on this? We have multiple opportunities. There are program accreditation opportunities within the institution, the higher education institution. There is hospital accreditation systems. Why don't we just mix this up? And of course, everyone went, well, that's not really the way we do it. And I said, well, I've been called responsibly subversive in the past, and I'm quite happy to be called that again. So let's actually cross-pollinate some of these processes and really start to understand what's driving the system. We tried to capture, in parallel with this, some of the best practices that were going on. So we tried to share experiences and learning. And by capturing those examples, our education colleagues understood just how fast service was moving, but similarly, our service colleagues actually understood how education was changing, because many of our service colleagues thought that education was still the way that they did it 35 years ago. So actually bringing into that dialogue is really important as part of this. Quality Improvement Scotland, which is the state-based agency that actually looks at the clinical side of things, was quite fascinated by the fact that education and service were working together. We were able to embed our education colleagues in our health service strategic planning processes so that they could actually comment and say, well, if you're going to be going in this clinical direction, what are the educational needs that will need to be met, both for your existing staff and for future generations of staff, and how does that play back to the accreditor in terms of their education system and in terms of our service system? So we actually ended up having this very strong dialogue together that we were then able to use with the two systems to say, this is what we're trying to do. We actually have a good understanding here, and this is how we can start to move things forward. So what we were able to do was to basically triangulate information in a way that previously hadn't been the case. And as a result of that, we were able to leverage some changes in the accreditation processes in both systems. Our basic premise was that quality care is delivered through teams. So doing it in isolation isn't going to work, and that we actually do operate in this very complex social network. So finding opportunities for this to happen, which meant that clinical nurses were part of the appointment processes of faculty. Faculty was part of our process. Clinical nurses were involved in the selection process, etc. All of these mechanisms help to strengthen the understanding of both systems, and then say, well, if we're trying to develop this new service, how can you help us in terms of the educational and underpinning that takes place? So the two examples are really fundamentally about the strength of collaboration, both across the education and service system, but also importantly, the strength of collaboration across disciplines in terms of having a unified message to affect policy and standard change. Thank you.
I feel like in many ways we're seeing, this could have been entitled innovations in accreditation systems. It's really remarkable from both of our speakers. Questions for David? Yes.
Darlene Curley. David, you mentioned, great progress that occurred that you participated in with education and a practice setting. But listening to Karen and what she was talking about, what suggestions do you have for her? And I'm not speaking specifically to Karen, but all of us that maybe are thinking the same way about connecting accreditation of education and practice. What suggestion would you have sort of like to get started, the baby step, so that we could get this moving?
I mean, I think the first thing is about relationships in terms of actually building some of those relationships so you can actually have a challenging discussion. And part of that discussion has to be concrete evidence. You've actually got to say, here is the problem. How can we solve this together so that if we want to improve patient care or we want to improve the educational experience, we've actually got to call these things out. We can't just simply say, oh, this is too difficult, we're not going to deal with it. But if you're going to deal with it effectively, you've got to start off with that relationship piece in terms of being honest with each other, being clear about what you can do at this stage. You may be able to say, this is where I'd like to get to in the long term, but I realize that that's a step too far at this point. But by actually just being clear about that longer term goal, it gives that directionality as well, because sometimes we take decisions in the short term that actually take us away from our longer term objectives. And if we're not clear about those longer term objectives, then we go down the wrong path. So build your relationships, get the evidence on the table, be specific, and have that joint commitment to move things forward that benefits both parties, not just one party. And that doesn't mean to say that you're both going to get the same thing out of it. I mean, some of the work that we've been doing at the National Council recently has been about implementing the Nurse Licensure Compact. And that's actually about talking to what's in it for education, what's in it for employers, what's in it for the nurse, what's in it for the regulator. We're very clear, for us, it's about public protection. For the nurse, it's actually about mobility and reducing costs. For education, it's about being able to deliver new modalities of education. And for employers, it's about flexibility and continuity of care for patients that are often crossing state lines. So, just being very clear about those and recognizing that we don't all get the same thing out of it, but by pursuing that solution, we all benefit.
Would you suggest a demonstration project or some kind of a pilot to get, practice and education and accreditors, on both sides of those together to try to start doing something? Or do we start with a bigger concept and kind of go big?
I mean, I think you do need to distill out the sets of principles that you're trying to pursue. But I do think you also need to then turn them into reality. So, go with the like-minded and willing rather than the ones that are screaming and punching. And then, demonstrate that it is possible and that there are clear benefits for everyone. And then it's the kind of early adopters and laggards and, just bite-sized chunks.
Thank you.
So I think we've created the problem. What David is trying to search for is a connecting piece between Karen's two circles. And I think I would agree with everything that he said about collaboration and pulling the two parties together, et cetera, et cetera. But we're the ones who broke it apart in the first place. I mean, there is no utility to education unless it improves patient care or health or wellness, whatever, vision you want. I mean, that's where it starts. And we have split the two apart. In reality, there is no difference between those two circles, or there shouldn't be any difference between those two circles. And I think David has an elegant way of describing that in his two examples. But that's the problem. So I think there both needs to be a vision and some action behind that vision, and then some practical guidance steps, which I think is what you're looking for, of how to do that. But I think the first thing is to say mea culpa, right? I mean, if patients or communities or populations, depending on your framework, are not at the center of your target, there's something very wrong with you as an individual, or you as a profession, or you as an accreditor, for that matter.
I mean, I would certainly agree with that. I mean, I've always found in the jobs that I've had that if you're talking to any clinician, and it doesn't matter, what variety they are, but if you actually say, well, how does this affect the patient outcome and the care that they receive, they are much more likely, because most people go into the healthcare profession with ambition to actually do some good. And by holding that as the focus of the discussion and saying, well, does that really take us closer to actually moving forward the quality of service, or does it take us away? And is that really, if it's taking us away, is that really what you as a doctor, a nurse, a physical therapist want to do? And really calling it out.
So I'm going to talk out of two sides of my mouth. I don't think I've ever used that saying before, because I agree with pretty much everything that's been said about why we're in it and what the long-term goal is. But I worry a little bit about the question of mandate. And this has come up in other workshops, the idea of there isn't a direct link between quality education and quality care. So if you talk to the education system voices, they might say our mandate is to produce people that are practice ready. And in care, in the care sector, people will say we're here to provide high quality, safe, patient-centered care. The end goal is the same for both. But I worry about the question of mandate, and do we have a risk of reducing this to, we're looking for now a linear relationship through the accreditation process between quality education and quality care. So just your thoughts on that.
So I actually think there's three kind of pieces to this. I think there is something called fitness for award, which is the kind of, has everyone fulfilled all the educational requirements to be granted whatever the ticket is, whether it's a bachelor's, a master's, or a doctorate? Fitness for award. There's also fitness for purpose in terms of is this individual, having completed the program, able to work in the reality of the environment? And I actually do think we've got a problem there, and I'll come back to that in a moment. And also there's fitness for practice, which is the minimum safety element that the regulatory boards put into play to say you're okay to let loose. we, in most professions, have a model that is trying to produce a generalist at the initial stages. But many of the clinical environments within which they have to work are in a specialty structured modality. So we're producing these people that could work in medicine or surgery or cardiac, etc., but they're not specifically tailored for that purpose. So there is a gap in that dimension that we need to figure out in terms of how we do that. And I think that's where transition programs have a role to play. That's where good induction, good support, and looking at how some of those programs can be accredited in a way that enables them to continue their educational journey on further. So again, in Scotland, we had a system where that induction program, in partnership with our education providers, was credited, and people were able to use those credits in their continuing ambitions to either pursue a master's degree or whatever. So I think it's not a simple one-to-one relationship. I think there is multi-dimensionality on this. But what is criminal is that we actually don't try and get those as close to each other as we can, bearing in mind that technology is constantly driving forward the system. So there's always going to be a little bit of a lag. But if the educators and the clinicians are talking to each other, we can at least reduce that gap. And having a program that is tied in for 5 years or 10 years, in today's world, that's not good enough. In today's world, we're moving at such a pace that there has to be the flexibility to address some of these issues and the mechanisms which are of a digital age rather than of an industrial age where we were using steam engines.
What other questions do we have for David? Please.
David, I'm really glad to hear you very clearly articulate this gap problem. And we've really struggled with it because on the one hand, our accreditation standards are supposed to be about the entry level practitioner. And we also have standards related to developing lifelong learning skills. And we also have a moving target with scope expansion, additional technology, new diagnoses, new procedures, you name it. And so we really are recognizing this problem, but have not come with any strategies to appropriately deal with it. And so I think your articulation is very, very appropriate. However, I think within the United States systems where we don't have gradation of the degree level, we don't have as much gradation within the educational experience. I don't know how to begin to approach this. So anything more that you would share about that, please?
Well, I mean, I think you've got to be careful that you don't throw babies out with bathwater, as they say. There are some systems already in place. I mean, I will just talk about NCSBN because that's what I do know about. We have a system, and this is the regulatory piece, okay? We have a system where on a 3-year cycle, we actually have an extensive survey of nurses in the United States. 125,000 registered nurses, 100,000 LPNs are surveyed to look at what it is a newly qualified entry nurse has to do. And on the basis of that, we then take some input from education colleagues, from service colleagues, and we have a group of experts as well. And we, on that basis, determine what needs to be in that initial entry to practice exam and what the passing standard should look like. So, I mean, I think that's a very sophisticated system. It's, in my view, the most sophisticated in nursing anywhere in the world. And we're actually seeing other countries come to us to see how they might adopt it in whole or in part. The fundamental question that you need to ask, though, have we got it right? And when we were discussing the passing standard in September of last year, one of the questions I asked was, how many newly qualified nurses in the first 2 years of their practice are coming before discipline committees for failures in terms of their practice? Not for drug abuse or various other things, but failures in practice, because what we're testing is whether they're competent to enter practice. And if we were seeing a large number of nurses coming forward on that basis, then I would be saying, we have not got this right. We are not actually got the measure, but that's not the case. We actually have very, very low numbers coming forward on that basis. So I think there are some checks and balances which relate back to the realities of practice, which you can then feed back to our education colleagues to say, we're getting this pretty right, but it is a 3-year cycle because that's the pace of change that we're seeing.
Wonderful. Other questions for David? Malcolm?
Why are we getting hung up on entry to practice? We have a continuum of learning, and I think everyone has subscribed to that, the accreditors and so on. You may have different accreditors for the different components of that continuum, but the focus of the activity is still going to be the patient or the patient-centered care in the words that you used, David. So yes, entry to practice is important, but it actually is less important than the continuum of practice for 40 or 50 years before you retire, like me. Before you get so incompetent you can't do anything. But I would urge people not to get hung up with the piece that they're most familiar with or responsible for, and look at this as a continuum. And I wondered what thoughts you had about that.
So you're absolutely right, and I think this is one area where we have not got a ready-made solution at the moment, but there are emergent solutions in other parts of the world which I think are worth looking at. If we are going to be able to capture a dynamic relationship between the educational needs of the individual, their competence in practice, and the patient outcome, we've actually got to get education and service working in a connected manner. So some of the work that's currently coming out of the UK, where the role of the patient in providing, and I don't think they've got it quite right yet, but conceptually I think it's very interesting. The fact that they have to capture, the registrant has to capture information from their peers, from their supervisor, and to have reflective, critical reflection on their practice. And that is part of their ongoing performance system, which then is extracted and utilized into the regulatory process and can be fed into the educational needs assessment. And I think Portugal has actually got a very good system for nursing, where nursing practice is an integral part of the electronic patient record. So the nurse regulator knows at the press of a button what are the common practices that nursing is currently doing, and by mapping that into where the system failures are, they can then start to identify what the continuing education needs are of some of the systems. So I would say there's no one country has got this right, but to get it right will require collaboration in a way that we have not seen before. This separation of powers is not going to give us the answer we want. We've actually got to create a system where we've all got a stake in the game and that we can all benefit from. And by doing that, we will then be able to reduce the burden of data, and we'll be able to increase the shared understanding.